Hi there and welcome to Laboratory Evaluation of the Eyes. I'm Dr. Alex Alexander, and this is the lab portion of your naturopathic clinical diagnosis for the eyes. And it says corrected there because I took it off the Moodle when I realized, thanks to a student, that there were a couple of missing slides. And this actually should say this is about the 50th time I've started to record this. And I'm wondering if that's owing to the fact that I just don't like the eyes, don't like working with them, don't like thinking about them, or if it's because I have been working for 14 days straight without a day off. Maybe that's it. So what structures might be involved in the eyes? Well, we have to recall the anatomy, and then we have to consider what can go wrong with each structure. So let's briefly look at the anatomy, and you can, I'm sure, recognize everything on this picture. And again, the internal eye anatomy. I like the PowerPoint with a little piece of tape like it's kind of holding that picture up there, even though I have to say it actually looks like it's not even touching the picture, so not very effective. So what are the conditions that we're going to talk about relative to eyelid and lacrimal duct structures? Well, we're going to talk about blepharitis, chalazion, stye, Dacrocystitis, and orbital cellulitis. And beginning with blepharitis, that's such a beautiful picture. That is itis of the bleph, or the eyelid, as it is in Latin, I suppose. And blepharitis is an overgrowth of bacteria, and it may be linked to having repeat performances of the styes and chalazion. And so you'll see the word stye interchanged with hordeolum, so let's just get that out of the way right now. You can pick which one you like, but they mean the same thing. You're more likely to develop this condition if you have seborrheic dermatitis on your face or scalp, rosacea, or lice. And I have the most amazing picture of completely encrusted upper and lower lid, live lice encrusted. So when we get to that portion, I'll put that slide up for you because it's so awesome. And also allergies. So we don't need to culture blepharitis. Laboratory studies are not routinely needed for Hordeolum, chalazion, or blepharitis. There's chalazion, and a chalazion is just a ramped up stye. It's just a more intense hordeolum, and it's a small bump on the eyelid that is caused by an obstruction of an oil-producing or meibomian gland, and they occur on the upper or lower lids, and they do cause redness, swelling, and soreness in some cases. They can lead to astigmatism, so they need to be treated or at least diagnosed properly. And visual exam and palpation of the eyelid is how you're going to diagnose this. A biopsy is only considered if it's persistent, because we want to rule out, or you're going to want to rule out, because I'm not treating the eye, remember that, meibomian cancer. No labs needed. Treat on symptoms only. Next, we're going to talk about the stye, or the hordeolum, and that's a pretty darn nice picture of that little guy. It's like a little pimple. So a stye, or hordeolum, is caused by bacteria from the skin that gets into the oil glands in the eyelid, and those styes are indeed similar to just common acne, and that can, occur anywhere else on your skin. You can have more than one at the same time, and they usually develop over a few days, may like a big old pimple drain and heal on their own, but they also can become a chalazion, and that's when the inflamed oil gland just blocks up completely. And if it gets large enough, the chalazion can inhibit or impede your visual field. Okay, so how are we going to diagnose this? Are we going to culture it? Well, no, because a hordeolum is diagnosed on the basis of that tender, red, swollen eyelid lesion that it is. It may be discharging pus. It may only be a few days in duration, but it's pretty simple to determine what a hordeolum is when you see it. A chronic chalazion is also diagnosed on clinical evaluation based on the slow onset, non-tender, non-red nodule in the eyelid of a few weeks or a few months. And then blepharitis, you're going to recognize that when you see it, basis of the red eyelid margin with that crusty debris. All right, and here's Dacrocystitis. And Dacrocystitis is one of those, you can either worry about it or you can just treat it and not worry about it. When I say worry about it, I mean you can think about a clinical course that it might take that might prompt you to go ahead and do the culture. So what is Dacrocystitis? Well, there's a nice picture of the anatomical structures involved. All right, have a look at that. And it can lead to orbital cellulitis. So dacrocystitis is extremely painful, and you've got this constant tearing thing going on, pain and pressure over the nasolacrimal sac, not sact, and applied pressure may or may not cause it to discharge. If it does, then you would want to go ahead and culture it, because why miss the opportunity? And then a CBC and culture and sensitivity could be useful in determining what kind of an infection it is, but you can just treat it presumptively. So the laboratory options are, again, culture may be indicated, and that's going to be based on your comfort level, and signs and symptoms. And dacrocystitis can lead to orbital cellulitis. I mean, we have this thing. I know you guys are really just learning to be doctors, and it's a great thing. It's a fabulous thing. So now's the time when you can, really start to think about and try on a bunch of different options that feel like you might want to do that. So I'm just going to throw a few options at you for cases where it's like the eye. Like I said, I don't like to treat the eye. You have to learn what you have to learn to practice safely. So while you're thinking about why do I have to learn all this ridiculous stuff, I'm not ever going to do this. Even Alex said she didn't like the eye. I don't like the eye either. I'm not treating it. But we still have to learn enough to practice safely. So we learn enough to practice safely, and then we decide, if this person walks in my office, I'm going to refer them, and not because I'm chicken and don't want to learn to be a good doctor in this area, but because you can only do so much. At some point, you have to decide the things that you're not good at, or the things that you don't want to be good at. And then you refer those things. And so the eyes are, if I were going to refer anything ever my first year of practice, it would be pretty much anything that didn't look like pink eye. If it didn't look like a hordeolum or the pimple or on your eyelid, if it didn't look like the crusty blepharitis, if it didn't look like the just the straight up pink eye, then I'm referring it. And the reason is because there's so many things that can go wrong. So that's why it's really nice to think about what it is that I need to know to practice safely first and pass my boards second, and then determine, okay, do I want to do this in practice? Probably not. So here we go back to laboratory options. If you're comfortable, maybe you love the eyes. Maybe the eyes are fascinating to you and you understand absolutely everything about them, and you just want to practice, as the most awesome naturopathic eye person you can, then great, treat all this stuff. But dacrocystitis can lead to orbital cellulitis. So if you see this walk into your office, the right answer is going to be to treat it with antibiotics, culture it if there is drainage, or refer it based on your comfort level. All right, and next we have our picture of orbital cellulitis. And that's a lovely picture, isn't it? That picture is a little bit of a reminder to me that guess it was last year, our then 8-year-old daughter got, I believe she only had dacrocystitis, but it may have, it was kissing orbital cellulitis if it wasn't already there. And it was, I think, most likely from something that got in her eye. Maybe she got hit with something at school, a tree branch, climbing a tree or something like that. But she definitely had this kind of infectious look to her orbit. And it was really, really scary. And she had all the constitutional symptoms. And, we didn't treat her. 2 medical people for parents. And we did not treat her. We took her straight to her pediatrician, who prescribed antibiotics immediately and watched her over the next 3 days. So this is one of those things that's an acute infection of the tissues immediately surrounding the eye, including the eyelids, eyebrow, and cheek. So it's related to any type of infection from a direct inoculation via the bloodstream or the nearby structures. She may have also had, this one may have been from a sinus infection. I think we never really figured out I think she did report to us that she'd potentially gotten some kind of something in her eye at school, but she had also been coming off of having a cold, really bad sinus thing, so we're not really sure. But anyway, so it doesn't matter. The bottom line is this is what the result was, and at that point it's time to treat it, because it can cause cavernous sinus thrombosis, hearing loss, blood poisoning, meningitis, and of course vision loss, optic nerve damage. It's usually unilateral, so you're just going to have it on one side. You're going to have a red eyelid. The orbital tissue is going to be all red. It's extremely painful. The eye movement hurts. It's a purulent discharge, and the child or adult will have fever and chills, malaise, and the constitutional symptoms of an unwell person. So this is where you really want to skip all those herbs, and you can do those later and just get that person the correct antimicrobial for their condition. And I'm a huge advocate of whatever the correct treatment is. And in this case, especially in a child, and I would compel you, not even in an adult would you consider anything other than antibiotics. But putting that person on a course of medication that is the best to treat the condition that they have is extremely naturopathic. That's our therapeutic ladder. And if where you need to be is antibiotics first, then that's exactly where you go, antibiotics first. Okay, orbital cellulitis, diagnosed on clinical picture. You can refer for a CT and an MRI of the sinuses and the brain, culture and sensitivity of the discharge or the wounds, and let's say a second thing on MRI. I don't think I mentioned MRI yet, but let's just stop for a moment on that. Let's say that we suspected that that this person got the infection from a metal shaving. Let's say that they were working with some kind of metal, and they were doing some kind of using a sawzall to saw up a piece of, I don't know, some kind of metal, and they suspect that a little piece of that metal is what went in their eye. You would definitely not order, most definitely, positively not order an MRI for a metal object. And I'd like for you to ponder why that might be true, and we'll talk about that in class. So anyway, this one is serious. Refer it unless you're very comfortable with the risk. Orbital cellulitis. Laboratory options, take-home message, treat it if you are comfortable, or better yet, refer. And I don't know how many times can I say this one is serious. It reminds me of the Wonder Pets. This is serious. Okay. All right. So conjunctival disorders for this class. We're only going to talk about conjunctivitis. Whoa, check that out. That's so awesome. And this nice little slide here I found on the internet, and I put the reference there. Differential diagnosis of red eye with Dr. Susan Lightman, Department of Ophthalmology, Moorfields Eye Hospital in London. And this was not copyrighted. I couldn't find anywhere on there where it said we couldn't use it, so I have linked you to the page and given her credit for this lovely slide. Shows you some nice examples of purulent discharge, chemosis, redness, and then you can see the papillae and the follicles. So what is conjunctivitis? Well, it's commonly known as pink eye, and it's an infection of the conjunctiva. And the conjunctiva or conjunctiva is the outermost layer of the eye that covers the sclera. And the three most common types of conjunctivitis are viral, allergic, and bacterial, and each one requires different treatments. So with the exception of the allergic type, conjunctivitis is typically contagious and self-limiting. So yeah, you can give it to somebody else, but it is eventually going to go away. Common bacterial causes are staph aureus, and then Neisseria gonorrhea. And common viral causes are adenoviruses and herpes simplex 1. So hyperemia of the conjunctiva or conjunctiva with tearing and sometimes discharge pain and photophobia. It begins in one eye, but it's going to go quickly to the other eye if you're not, or your patient is not extremely careful. And acute bacterial conjunctivitis lasts about 2 weeks. Yeah, 2 weeks, long time. Viral conjunctivitis has little to no exudate and can produce symptoms that are, I would say, severe and disabling for 2 to 3 weeks. Treat presumptively in most cases because the most important thing is to prevent the spread of disease. So get treatment on board, whatever your treatment is, and we're not supposed to talk about treatment in this class, but there are some really great naturopathic treatments for pink eye, some really great over-the-counter treatments for it, so you don't always have to use antibiotics. If it's bacterial, of course, you kind of want to. And anyway, so as Neisseria gonorrhea can be an infective agent diagnosis, it's important to know what this is. So that if you suspect that it's gonorrhea, the healthcare provider is going to have to report that. So that might be a case where you want to do a little more investigative consideration. Labs may be needed. Laboratory tests are not usually necessary unless this inflammation is severe and the conjunctivitis is recurrent or has failed to respond to your initial therapy. And conjunctival swabs are going to you're going to swab both eyes, and even if the infection seems to be only on one side. So you're going to go ahead and swab both sides anyway, and swabs should be taken from the lid margins as well if there's any evidence that they're involved. And then you want to consider referral in cases of, atypical, recalcitrant, or refractory to treatment, or if it's a unilateral presentation. And so why would I say that? Well, because if it's really bad pink eye that's not going away and it's only staying on one side, then you have like the most OCD clean person in the world that's somehow never sleeping, or they've, somehow patched the other eye barrier, some sort of barrier, so it never gets in the other eye. So you get my point. If it's unilateral, then it's probably not simple conjunctivitis. Important considerations for the eye. I want to point out fungal infections. Fungal infections of the eye, culture is imperative in patients where fungal infection is inspected, and quite frankly, it's really difficult to ascertain the difference between fungal infections and bacterial or viral on just signs and symptoms. And so we're going to need a good patient history. And, fungal infections are a lot of times those infections of the eye that seem simple in the beginning and then they don't go away. And the patient has hard contact lenses, or the patient works outside with the soil. This is where we're seeing a lot of fungal infections now. So culture is imperative in those patients. And the treatment can be toxic to the epithelium, so it's usually administered for a long duration. So you need to guide your treatment with a positive culture. So you can go ahead and, start the patient on something, but if you determine that something doesn't work, then you've already started the culture at the same time. So let me just make sure that makes sense. If I culture your eye and give you an antifungal the same day, then 3 days later when I've got the culture back, if your eye's not better, I can look and see why. Like the culture may say it's cultured this organism and it's sensitive to these agents, and I may look at what I gave you, and I didn't give you one of those agents, so I need to switch you over to a different microbial antifungal at that point. If a fungal etiology is strongly suspected on the basis of history and physical exam, that's when you would do the initiation without the culture. But otherwise, there's really no end point for treatment that's easily determined on these fungal infections, i.e., am I going to treat this for 10 days, 14 days, 30 days? How long am I going to treat this for? And a lot of these fungal agents are super toxic. So you want to make sure that you know what you're treating. And again, you know what I'm going to say, refer. Okay, important considerations for the eye. If an intraocular foreign body is suspected, and I've said this a little bit earlier, a CT scan is the study of choice for the localization of the foreign body. And ocular magnetic resonance imaging is contraindicated if you think the foreign body may be metallic. So in summary, blepharitis chalazion Stye, Hordeolum AKA Stye, do not culture. Okay, culture if you want to, but there's really no point. Dacrocystitis, treat, culture, or refer based on your comfort level. This is why you get paid the big bucks. You can decide if you want to culture. I don't know. It's up to you. Orbital cellulitis, refer or treat immediately. Refer or treat immediately. And you're definitely going to culture that if you are the one that's treating it. Conjunctivitis, culture or refer if refractory to treatment. Fungal eye infection, culture or immediate referral. And then do not order an MRI for suspected metal foreign body. This is where we normally end our fun together, you and me. But I'm going to go ahead and give you a little 3-page, I think it's 3 slides of symptoms cheat sheet for the eye, conditions of the eye, because they're incredibly difficult to remember. So let's go with sudden onset of pain is suggestive of an intraocular foreign body or acute closed angle glaucoma. So sudden pain, think those two things. Gradual progressive pain is more suggestive of a corneal infection or an ulcer, iritis, or scleritis. Acute onset of mild discomfort or no discomfort with our sectoral or diffuse injection is going to be characteristic of episcleritis. Halo vision or loss of vision may occur as a result of corneal infection or ulcer, and patients with corneal abrasion, foreign body, also may experience vision loss. Halo vision or blurred vision, accompanied by systemic symptoms including headache, may be misdiagnosed as a migraine, particularly in patients with a history of migraine and nausea and vomiting that may mimic those of cardiovascular disease or intra-abdominal disease are seen in patients with closed angle glaucoma. So what's this slide telling you? It's basically saying just because it looks like a migraine and they've got a history of migraine, you still should investigate the possibility of closed angle glaucoma. Light sensitivity is experienced by patients with iritis, scleritis, or corneal abrasion, foreign body. And then page 3 there, I think the noise in the background probably just kicked up a tiny bit. Foreign body sensation is associated with corneal abrasion and actual foreign body, blepharitis, because you got that crusty stuff, keratoconjunctivitis sicca, which is dry eye, associate that with autoimmune, and conjunctivitis. Itching is suggestive of allergic conjunctivitis, but you can also see that with viral conjunctivitis and blepharitis. Crusting of the lashes, burning, and tearing occurs in patients with blepharitis, keratoconjunctivitis sicca, and conjunctivitis. Conjunctivitis is characterized by that matting discharge that's yellow, green, clear, or white. Pain and tearing are experienced by patients with Dacrocystitis. And I will leave you with this lovely picture that I could not reference because I couldn't find a reference for it. It's all over the internet and on everybody's blog, but I have no idea if it's copyrighted, so I apologize to the person who took this picture if I've stolen it. You can send me an email and I'll take it off my PowerPoint. Okay, guys, thank you so much. Have a lovely rest of your day.